and welcome to another episode of CP Diaries. This is one of my most exciting episodes that I get to do, which I'm really happy I get to do. I'm here with two really accomplished women, Sarah and Grace, and they are from the organisation known as PAEDS, which you're going to get to learn about today. Welcome to the show.
Thank you, Natalie. So happy to be here.
Just to give our guests some frame of reference, I'll let both of you introduce yourself. Grace, did you want to go first? Tell us a little bit about you.
Sure. Yeah, no worries. Okay. So yes, my name is Grace. My background is very similar to Sarah, so I'll try not to steal all of the same things, but we are both paediatric intensive care nurses. We actually worked together in the ICU for many years, shared quite a few different roles. I'm a mum of 3 kids. I live on a little hobby farm between Kyneton and Heathcote in Victoria. Just super passionate about the little business that Sarah and I put together, now that we don't travel into Melbourne and work in the ICU as frequently. That's me pretty much in a nutshell, I'd say.
Awesome. Sarah?
My name's Sarah. I am first and foremost a mum of 4 little ones, aged between about 19 months and 8. It's what happens when you get to 4. The last one sort of gets a little bit forgotten. No, she's very dominant. 3 boys and a little girl, and she rules the roost, that's for sure. Also a paediatric intensive care nurse. Just taken a little bit of extended leave to complete my master's and also to sort of establish our NDIS component of PAEDS Education, which I'm sure we'll talk a little bit more about too. I also live on a farm about an hour from Melbourne.
Amazing. And I love what you mentioned there. What are you doing? Was it your master's or your PhD you said you're doing?
Yeah, so I'm doing my master's in advanced nursing practice, which Grace has already completed pre-kids, which is far wiser than trying to do it with 4 children.
Look, it's doable. It's not easy.
It's doable. Yeah, that's right. All of us sit down and do our homework together. It's really fantastic. And at the moment, I'm actually doing a really big sort of subject in paediatric rehabilitation, which is just so exciting because it really aligns with what we're doing at PAEDS Education.
And based on that little summary you both gave me there, am I correct in understanding you guys met in intensive care and you built this business together?
Yeah.
So Grace and I have worked for years together. So many years. Look, we've done a lot of clinical work. So I think I've been at the hospital for almost 16 years and Grace is a little bit longer than me. We both worked in sort of education roles and really advanced our clinical skills. But it was when we were placed together in a role as clinical nurse consultants where there was a lot of quality and safety work. Our manager thought we would work well together. And it was in that role that we realised that actually we've got a passion for really educating outside the hospital realm as well, and that whilst we've got a really big background in reactive healthcare and treating the sickest and the most severely injured kids in Australia, we really have a passion for proactive education, so outside those hospital walls. And I think that came about really predominantly when we had children and moved to the rural areas. We realised that there's such a need for that proactive education.
That actually brings me to my first question that I guess both of you can answer in your own way or take turns. How did you come up with the idea for this project, this initiative, PAEDS, and tell us a bit about what it actually is?
Yeah, so, PAEDS, firstly, the reason why we called it PAEDS is because if you've ever gone through, the health system with your children or as a child, it's referred to as paediatrics, and so we often will shorten it down to PAEDS. Basically, we first got into this when both Sarah and I started doing some teaching for an organisation where we're teaching advanced life support out into other health professionals in the community. And a lot of those health professionals were in rural areas and they would see some children, but they wouldn't see children all the time. So it wasn't sort of like they weren't paediatric people themselves, but did have to look after kids, like in EDs and urgent cares and stuff. And we sort of walked away from that really because both of us were going through a period of time in which we were moving away from Melbourne. And we really sort of thought, I wonder whether we could take, our really specialist paediatric skills, which are very centralised into a metropolitan area, and bring them with us out into the rural spaces in which we're going to be living, and really be able to empower communities, specifically it was healthcare professionals at that time, with a bit more confidence around how children deteriorate and how to look after kids when they are unwell. And then it sort of evolved from there. So I very much started, looking at healthcare professionals, but we expanded that because we realized that we actually could extend this education and this empowerment and these skills to parents and carers of children. If people are more knowledgeable and well equipped in what to do with their kids to prevent accidents and injuries or manage illnesses, in rural spaces in particular, where it takes longer for you to access those specialist services, then that's going to have good outcomes for kids. And then, of course, that's sort of extrapolated out as well to our lovely families who are caring for children with disabilities or complex medical illnesses in rural and regional spaces too, because, those kids need specialist training. We want to empower their villages and grow their communities to be able to help support those kids like within their home, within their community, so they're not having to travel so frequently into metropolitan places for their treatment where possible. So I suppose that's probably sums it up in a nutshell, very quickly and broadly.
And Sarah, is there anything you want to add to that?
I think Grace has summarised that beautifully. I guess we wear many hats. We're sort of multitask extraordinaires, and we love being able to tailor and customise all of our programs to the individual needs of our clients and our families, and that's very important to us. And we do that in the healthcare sector, and we do that in the community sector, and that's a really big part of our program and I guess our point of difference.
There were a few things that it touched on that I thought of as I was listening to you both speak. The first thing I thought of, you were talking about how it's important. You were sort of inspired by your own experiences living in regional communities. I remember, obviously, as someone with a disability myself, I used to have to make the annual or biannual trip into the city, and even that was a big excursion. And I was just living in the outer suburbs or the southeast suburbs. So even that, it was like my parents would have to take the day off work. They would get me in the car. It would be a big trip there and back, and peak hour traffic by the time they got me in the car. So obviously that was part of what inspired this, that you identified that gap. Would that be fair to say?
Yeah, I think, there's definitely that travel gap. But, I think also we know because of our work that we did when we were in intensive care, both Sarah and I worked in retrievals for a period of time. And, in retrievals, we would go out, often to very rural and isolated places, and we would pick up children who were very unwell and transport them back to, a metropolitan hospital where they could have that definitive care. And you sort of see, when you're collecting the child, that they need to go where they're going. They need that help. But you can sort of see you're ripping them away from all of that support network when that happens. There's usually one parent who might be lucky enough to travel with the child. If they're lucky, that's not always the case. But essentially it's one parent who'll come with that child, because often the other parent needs to care for the other children at home. And if they're coming from farming communities, farmers, their work is not 9 to 5, so there is a massive amount of, social, economical, stress that is related in children either coming in, for a planned appointment or for a trauma, sudden deterioration or illness. And so I think, we really just recognize that, this type of, as Sarah was saying, proactive approach could make a massive difference and hopefully an impact on, reducing the amount of times that children and their families have to experience that.
And look, the other thing you mentioned there, Grace, and this is something you both mentioned in the email correspondence that we've been having in the lead up to this chat, is you use the term a village, and you've used that more than once. And I think that kind of does touch on that idea. Can you expand on that more, though, either one of you?
Yeah, I think that, as a parent, having your village, a village that understands who you are and what you're going through is just so crucial. Navigating those years with your children is one of the hardest things you can go through. Now, when you are in a city environment where there are far more people, there is more opportunity to connect with like-minded people or with people who are at the same stage that you are at in your parenting journey. Now, this parenting journey, it doesn't just stop when your kids turn 2 or 3, or when they sort of start going to preschool or kindergarten. It's throughout their lifespan. And even you as an adult having your village around you, whether you have children or not, is just so crucial for navigating, the tough times, the good times. And what we found in regional rural areas is actually there's a high percentage of children living with disability in regional rural areas compared to metro.
Oh, wow.
And that's something that's really, it's quite alarming for a lot of people. But it's also, the reality is that these families don't have a village to support them through these really tough times. And let's say we've got a child who is living in a rural town who has a disability. They may be the only child in their town who has that disability. All of a sudden, parents can no longer work because they've become the primary carer. There are no support coordinators. There are no carers who are equipped with the skills and knowledge to care for that child adequately. So the parents stay home. Usually the mum stays home as the primary carer. She no longer engages in social activities or community activities because she can't and because no one understands her child. And so all of a sudden she loses her identity, she loses her village, she loses her support and social network, and she doesn't know how to include her child into the community or integrate her child into community activities. And so we want communities to become villages where they understand every child in their community, regardless of their ability or disability, and where they can support them in practical and meaningful ways. And so our program exists to be able to build and strengthen communities by training local carers, so keeping jobs in communities, by enabling mum to then return to work or at least engage in some social activity as well, and reform those connections that are going to support her through the parenting journey, but also beyond.
There's so much I want to unpack.
Sorry, I've just dropped the bombshell.
I'm like, I got to ask her this, but I got to ask her that, but I got to ask her that. So the first question I want to ask is, you mentioned that crazy thing about there being a higher proportion of people with disabilities in the rural communities as opposed to metropolitan. Do we know why that is? Is there a scientific explanation?
Yeah, that's a really good question. This is sort of data that has come out just recently. It's been known for a little while and it's not well publicised, but the NDIS data has revealed that, yes, there are more children living in regional, rural and remote Australia on the NDIS with various forms of disability compared to the metropolitan. Now, we don't know, there's no reasoning behind that. The reasoning that has been put forward is that potentially families move to these areas because they feel more of a community, a sense of community. In saying that, we know that actually that's not always the case, because a lot of communities don't understand disability and don't know how to support those with disability. And also these families, whilst they get a little bit more funding for living in more remote areas, they use that funding up very, very quickly because travel becomes a huge part of their expenses.
Right, of course. So it's kind of ironic.
Yes.
The other thing I wanted to ask both of you is, well, it's more of an anecdote, really. When you were talking about how, they feel like they don't have people who understand them, what it's like to have a child with a disability, not just the emotional ramifications, but the economic, all of it. It reminded me of a wonderful colleague I have who has a daughter with a heart condition. And when the baby was first born, obviously she was referred to her local community mothers group, and she felt like she just couldn't jive with the other mothers because their biggest conundrum was, I'm scared to cut the baby's nails. And it's like, you know what, your issues are like a drop in the bucket for me. And do you observe that kind of mentality with the parents you work with, and how do you address that?
Yeah, 100%. I think you really hit the nail on the head on one of the challenges, for, like, I am also a mother who's got a child with a heart condition, but, I suppose I've got that difference of, my background. So there's, I've automatically got a level of understanding of how to navigate. I had 2 children who didn't have a heart condition prior to having one with a heart condition. So that actually became really, like, what you're sort of describing became really obvious to me when I had my 3rd child living rurally. And I just thought, I'm really lucky because I know And, that even was to the point where I actually identified her heart condition and got it diagnosed, because I was able to pick up on the signs and symptoms. But, most people aren't pediatric nurses before they become mothers, that have worked in ICU with children with heart conditions. So, like I think that you're right. There's an element of people, going through something, which is a very unique experience, probably within a community, but they're not the only ones going through it. And we've actually found through doing our training that we've also had the honor of being able to connect people to other people and be able to maybe even create a virtual village for them in some situations, where we might be like, I actually know somebody who's got a child with this really rare genetic diagnosis as well, and why don't I connect you with them? They might not be, they might be a few hundred kilometers away from each other, but they can at least talk about that really unusual experience about getting diagnosis. They're still going through like a period of like not knowing what's related to the genetic condition and what isn't. And, there might only be like 2 or 3 of these children in the world. And, it's a really nice honor that's sort of developed as a part of what we're doing, where we're able to also help make connections for people and, acknowledging, like as Sarah said, every parent or carer of a child, they want to speak to other people who are going through a similar sort of situation so that they can navigate this crazy time together. So yeah, it's nice to be able to do that as well.
So I just want to ask and break down the service a bit more from a really surface level point of view. Like let's say I'm a parent and I have a child with some kind of disability or chronic illness that needs attention, and I come to you. What does your service look like, and how do you cater to my needs? Tell me more about that. And my child's needs, I should say.
So I guess just to sort of create a broad picture, and then I'll get to your specific questions. So PAEDS has sort of 3 arms to it. We have a healthcare arm where we train healthcare professionals, predominantly in regional and rural areas, all about paediatrics, and that might range from disabilities through to life support, through to specific learning needs that they have for their hospital or their centre. The second arm is that we do first aid training. So that is in baby and child or infant and child first aid training, as well as accredited first aid training, and predominantly for businesses that look after kids. So, allied health providers, as well as schools and kindergartens. And then the third arm is our NDIS care arm. And we sort of can incorporate all of the arms together. But if you were a parent or a carer of a child who had a complex medical need or a disability, we firstly do a needs analysis with you. We have conversations about what your child requires from a disability or a medical perspective, and then also what your carers require from a learning perspective. And the carers might be your village, so your immediate family, or it might be a village that includes your extended family or community. And then that also incorporates your carers as well as your educators for your child if they're attending an educational institution, kindergarten or school. And we develop a program that is tailored around the needs that they have from a learning perspective. So that might be that you actually have never had training on how to manage your child's PEG, or it might be that your carers are actually not skilled, have never received training in how to care for a tracheostomy or home ventilation or a nasogastric tube feeding. And so we have a hybrid model of training where you are immediately what's the word, Grace? Immediately put into our online learning program, which has modules related to your child's care. And they're quite generic based, but it means that you get that immediate learning whilst we are organising face-to-face training, which we generally do in a very, very timely manner. So one of the biggest issues that families have when they're trying to access education and training is that they have to wait a really long time to access that education. And for some families, that means that the child cannot attend kindergarten or school until they've got that training. So we try and get this to you in a really, really timely manner. And we have a number of paediatric nurse specialists around Victoria who we can utilise to provide that training, which is how we get it done so timely. And so we'll come out to your home or to, say it might be a centre, an allied health centre, or it might be your child's kindergarten or school, and we can do the face-to-face training element of the program to whoever needs it, really.
It sounds so good, like on so many levels. The fact that it's so uniquely tailored to the family's needs, and you've kind of broken down. That was going to be my next question, but you've kind of covered how you do that. But I love how you also make it competency based. So it's fit, thinking about what you said. You know, there are people who don't know how to do a peg or a tracheotomy, and the average person doesn't enter their realm of existence until they're put in that scenario. So how do you find people go with learning that stuff?
Yeah, look, actually I think we've done pretty well with that. Like, we'll have backgrounds which can range. So we might have registered nurses who've got, background in adults, but just not specifically pediatrics. And they just really want to have that opportunity to pick our brain and really understand the differences. We might have disability support workers who've got, again, like a little bit of a background from their training and some things. And then we might just have family members who really just want to have, again, a bit more of an opportunity to, build on their current knowledge that they've got, because obviously going through like maybe the diagnosis phase and like being educated in hospital, like it's a bit of a whirlwind, like they're getting, like it's quite overwhelming and they often don't take in all the information. So they're building on what they've already sort of learned. And you'll see a lot of aha moments. I think that's the nicest part of it. I'm sure Sarah will agree. When you're able to explain something and everyone's suddenly like, oh, yes, I get it now. I really get it. Like, I know I was told that, but now it makes sense to me. I think even though we really are teaching to a broad background of people, I feel that the product we've got, it gets it right because of the fact that we have a theory and a practical component. So before we even go in there, everyone's had an opportunity to learn the theory. And so when we're going in, like they've got questions ready, they're already reflected on what they already know. We really can just get straight into the nitty gritty of like, how does this apply to this child? What are you going to need to know to keep them safe? What are the signs you've got to look out for? And yeah, like I feel like we've got it working quite well to meet the needs of everybody.
I think one thing I just want to circle back to before I forget, we've talked a lot about the regional factor here, and that was initially the inspiration for this program. But is it available nationwide or statewide, or what's your scope?
Yeah, so at the moment, yes, everywhere in Victoria we will go to. So whilst we are regional rural based, and that was the passion sort of behind starting it, was the lack of availability of this in those areas. We absolutely do cover metro as well. Our dream is to make this nationwide. We have lots of connections around Australia with fantastic paediatric nurse specialists, so that is absolutely our dream. At the moment, we can provide an online component nationwide, and we're in the process of working out how we might make that more accessible from a practical perspective as well, reaching those really rural areas where we might not be able to access in a timely manner, working out a program that we can access those people. So yeah, watch this space.
Oh, awesome. Okay. And we definitely will, because we obviously, as a service that caters to families as well, we often get calls from families who are super overwhelmed when they first call us, especially if they've got a newly diagnosed child. Tell me about some of the challenges your clients or patients typically are dealing with when you first work with them.
So it can really vary. We interact with people at various stages of, I suppose, their journey. So we might be asked to come in at that initial phase, or we could be asked to come in, like, for example, in a couple of days' time, I'm going to go do training for a family and their child is 13, and they've got a established group of carers, and they really just want me to come in and just make sure that everyone's up to date and refreshed. So, it obviously can be very different for different individuals. But yeah, look, I think for that initial diagnosis, there is definitely that sense of overwhelm. There's a sense of competing information. So they might have been told one thing from one person and then something completely different, by another person. So they really just want to be able to have that opportunity to ask a lot of questions and clarify. And maybe also, I think the other thing is just probably reassuring a lot, like when we're talking about parents as well, reassuring them that they do know their child best, and, demedicalizing some of it as well. Like, even though we're coming in to teach a lot of that sort of medically based stuff, I think our role is sometimes also to go, do accompany that with all of your parental instincts, and, you are still their parent at the end of the day, and trying to help them balance that new life outside of the hospital and outside of that really acute environment, and now what home life looks like.
Yeah, I like that you mentioned that, because there's a growing school of thought that, and I'm sure you know about this, that patients are to a certain degree the best judgments of their care because they know their own body or they know their child. What are your feelings on that, or what are your thoughts on that? Do you try to factor that in? It sounds like you do.
Oh, absolutely. One of our biggest mantras is that you are the expert in your child and your child's needs. And when we go and teach healthcare professionals, one of the biggest things we say to them is the parent and the child are your best indicator of how unwell they are, or you use them as your biggest part of your assessment tool, because you, as a parent, no one knows your child better than what you do. And also, talking about the child as well, they know their body and they know what's normal and what's not normal for them. And so understanding, if they're nonverbal, understanding what their forms of communication are to alert you to the fact that something abnormal is happening to them is very important. And you can only get that information from their predominant carers, which is usually their parents.
In addition to the online classes, in addition to going to their homes, in addition to doing face-to-face programs, is it done one-on-one, or do you ever do class settings? Because I know you said you create a sense of a viral community for your patients or clients.
And look, it depends on what sort of course we're running, because all of our courses are so incredibly customized. For some families, it might only be 1 or 2 people that we're teaching. It doesn't matter the number of people because it falls under the NDIS funding. But it also could be, that we're teaching a whole bunch of teachers. And so when Grace was talking before about the different challenges that these families face, it really does come with the stages of life that their child is at, or the stages of diagnosis, or that post-hospital phase as well. And for some of these families, some big challenges happen when their child's about to enter into the education system. And so sometimes we will do courses for kindergarten teachers, because a child's about to enter their service with a nasogastric tube and a tracheostomy, and they don't know how to navigate that. So we might do a class with the parent as well as all the kindergarten teachers, and we'll incorporate their accredited first aid training into that customized course around, whatever medical apparatus they may have. And that's a really beautiful way of covering all the bases. We become sort of like a one-stop shop pediatric service where they can, go, well, yeah, we actually need to do our first aid training, but you guys actually can add on those complex modules as well, which is just a really wonderful thing to be able to provide these providers, because they often have to get multiple people to do this for them, but they're getting all the information from the one place and it's consistent. And I think that's a really big part of what our service is. It's consistent in the message that we're providing.
Yeah, and I'm actually really glad you mentioned the preschool thing, because it's actually a classic example. It's not just about that immediate thing of, oh my God, we have this child who has this condition that we have to manage. It's that thing of allowing them to go out into the world and still have some degree of normalcy or ability to blend in with their peers. And we do, like, even on our front, sometimes we'll get people calling us and say, we're a local primary school, we're about to have a little boy join our school who's got cerebral palsy, and we're not sure, we just want to make sure we understand the condition. And it's so good that you provide that. It ties back into that village theme. Along with the classes you run, you do hand out learning materials. Can you tell me more about that?
Yeah, so it sort of depends again on who we're teaching. So one of the other things I just wanted to mention, which ties in a little bit about what we've been talking about, is whenever we develop any of our programs, we also do that in combination with the parent carers or children as well, if they want to be involved. So we often don't move forward unless we've had a conversation with the parent or the carer around making sure that they're happy with what we're going to come in and teach as well. So we like to make sure that our teaching is very holistic. So the other thing that we might hand out specific stuff, which is generic in nature. So that could just be resources which are, generically created through associations like yourself, like your association, Natalie. Or we also can develop resources. So some of the resources that we're asked to develop might be what to do when the peg falls out, and this might be for the respite care that the child gets, before or after school or during the school holiday program. We also help with care plans, for orientating, new support workers into the network, so we can put together the care plans that they might need to refer back to, if they're on a night shift and the parents are sleeping and they want to know how to X, Y, Z. So again, this I suppose is where we bring in our nursing knowledge to it as well. So it goes that little step further than just coming in and doing the education, but we really try and look at ways that we can continue to support the development of anyone who's caring for that child, just to keep them safe and to keep everyone feeling really well informed and empowered to be able to care for that child safely within the community as well.
Yeah, it's so good. And generally speaking, what's the kind of feedback you're getting from people who've done your program?
It's been really lovely.
Yeah, it has been lovely, hasn't it, Grace? And look, that we don't want to sound, wishy-washy about that, but so many parents say to us, we've been waiting for this for so long, where have you been? And to us, that is both, it's both horrifying that they've felt so alone for so long, but it's also such a feeling of accomplishment that we're feeling a gap that really, really needs to be filled. And, we have been at the Source Kids Disability Expo for the last 2 years, and to have parents come up and have, like Grace said earlier, those aha moments, not just in learning about their child, but in, oh my goodness, yes, this is exactly what we need. We want to feel educated in a meaningful way, and that is completely tailored and customized to our child. We don't want something generic, because we know that every single child is different. And like you have said before to us, Natalie, one child with cerebral palsy is very, very different from another child with cerebral palsy, even if they might be on the same scale. They are so individual, and that is why our program is so individualized, because we want families to know that we are coming in teaching them about their child, not about someone else's. So yes, very, very positive feedback from families so far.
That's so good. And I just want to touch on something you said there, Sarah, because you talked about it was sort of simultaneously heartbreaking and great, because people would say, I've been feeling so alone until this moment. I think there's this attitude, not just with disability, not just with the medical system, but when you're preparing for adulthood, you're gonna be on your own, and how are you going to deal with these things? We're sort of conditioned on a societal level to think that we're going to go into adulthood in a silo type environment, that it's all on you. And I think this is like a perfect example where not only is that not true, it's to someone's detriment.
Oh, absolutely. No one should be going through any stage of their life alone. We know that that's not going to be helpful on any level. And I think you're right. I think that there's this automatic, you turn 18, okay, off you go, you're on your own. Whether you have a disability or not, it's not something that we can do. We're not wired to be able to do life alone.
Yeah, so true. So true. No man is an island, I think, is the mantra, right?
Absolutely.
Grace, did you want to add anything to that? Because I know there was a moment where you were both wanting to jump on that question.
Oh, we always do. We both love to chat, so I don't know how we manage to talk to each other half the time. No, all I was going to say, I actually have been really surprised by how well received the online modules have been. Because we obviously, this is what we do is very different, and I was very worried that we're offering something that's online. People often really, really love the face-to-face stuff, and so there was this element of I'm not sure how well that's going to be received, but we get this really good feedback when we go and do the face-to-face around, oh, that was really great. We really actually loved doing the online stuff, because it is really short and sweet. It's not hours of learning or anything. It's just a little taster. I'm so sorry, my bunny's jumping around in its cage again, if you're wondering what that noise is. It's just a little taster of, just to get everyone in the right headspace for us when we come out. So, yeah, that's been really pleasantly surprising, I think, as well.
Talk to me about what your hope for PAEDS is in the future.
We have pretty high aspirations, I've got to say, Natalie, in regards to what we would like to do with PAEDS. I think when we first entered into doing this, as I sort of mentioned, our scope was very much healthcare professionals. But as our scope has broadened, we've also become more aware of all of the different challenges. And obviously, as we do that, Sarah and I are the type of people that, when we see a problem or an issue, like we become really invested in that solution. And, so the more we sort of continue on with PAEDS and PAEDS education, the more invested we are to becoming, a solution to the problem that we're identifying. So, we want to try and be able to reach as many families as possible. So we're going to try and figure out the best way to do that. And, as you say, like we know that this is not just isolated to Victoria. In fact, probably the other states are in just as much of the same position as what we are in here. So yeah, like we're pretty out of the box thinkers. We get pretty creative, and we're not scared to, give things a shot. So I definitely think, we would love to be able to be accessible to anyone wherever they are within Australia, and have that be a really meaningful experience for the parents and the carers who do access us for training. So yeah.
I was just going to say that Grace and I consider it such a privilege to have been provided with the level of training and education that we have had. And we don't want to keep that to ourselves, but it's quite a challenge spanning that healthcare community and now NDIS space. And as we grow and become confident, and also feel a level of acceptance in those spaces, our confidence with what we can offer just grows. And I think that that's really exciting for us personally and professionally too.
And I want to expand on that because you mentioned the NDIS, and we need to cover that bureaucratic aspect of it. If someone wants to access your service, how do they go about that in terms of NDIS funding?
So, look, people find us in a variety of different ways. So sometimes, allied health professionals sort of find us and refer us to parents or carers, or so people might find us through our website, or they could find us through their plan manager. So it sort of depends on how they find us. But at the moment, we currently are not NDIS providers, but what we do is we align our services with the NDIS pricing arrangements so that it's really simple for people to be able to use us, with their NDIS funding. And what we come under is the disability-related health supports and nursing supports. So what we provide our education and training as clinical nurse consultants under that. So in doing that, we're able to develop all of these programs, give that face-to-face training, and obviously acknowledge that we're coming from that nursing perspective in order to do that.
Okay. So I just want to clarify and make sure I understand, particularly for our viewers, and you can elaborate if you need to. So you're not a registered NDIS provider as yet?
Yeah, that's right. So we did look at going through the auditing to become one, but there actually isn't anybody in the NDIS system who does what we do. So they actually would have to create a whole new category for us. But so far, we actually have found that it hasn't been necessary for a lot of people for us to become a approved provider. That in invoicing, that the way that we do, using the pricing arrangement, which we obviously don't have to, but we have agreed that we will, makes us accessible for everybody. And so in doing that, we've generally not had any issues for people who need to use our services to get that approval, or ourselves, to be able to get that funding across. So at the moment, it's working the way that we're currently doing it. If it ever becomes a point in which someone's unable to access us, then of course we'd circle back to whether we need to become a registered provider, of course. But at the moment, I suppose the cost and time that would justify it doesn't seem to be necessary.
Okay. So just to clarify, NDIS users can still use their NDIS funding because it's in alignment with the pricing arrangements to use your service. So they're not paying out of pocket. Is that correct?
Yes.
Okay. Just that's the most important thing. So we understand the basics, because NDIS is a minefield, and sometimes you have to break it down into its most basic level. And I get it, because we're a registered provider and the auditing can be a nightmare. So we totally get it.
Can I just add one more? I just want to add one more thing there about the funding too. If it's a kindergarten, we can support the centre to access the Kinder Inclusion Support Program funding as well, and that's a really wonderful way to get funding for your educators. So that's something else to keep in mind.
Another question I wanted to ask you, bottom line, if people want to get in touch, learn more about your services, where can they go? Who can they talk to?
you can head to our website, which is www.paedseducation.com.au. You can send us an inquiry on there, which is where generally most people get in touch with us. We're also on Instagram. We have lots of bite-sized information on Instagram about keeping your little ones safe, which we are going to add a lot more about children with disability too, because this has become a new aspect of our training. So you can head to PAEDS on Facebook or Instagram.
Awesome. I mean, and of course, those links will be provided. Now, before we head off, I just want to leave it an open space. Is there anything we didn't cover? Because we've been talking a lot, but there's always so much more to cover, right?
Oh, look, Grace and I could talk all day. We just want, we want people to know that we exist because we know that we can provide something that's really meaningful and helpful for families. And education is power. And, we can provide education to empower families, carers, and also children. That's really important to us as well.
Yeah, well said. That's an interesting point of it. Sometimes we get so caught up in talking about the parental aspect that we forget that, kids need to be educated and empowered about their bodies, regardless of what the circumstance is. So that's a really fair point. Hopefully we can meet up again. And if our viewers want to reach out to you, we'll have the details below. Thanks for joining me.
Thanks, Natalie.
Thanks so much for having us.